All right. Hopefully everyone can hear me in the room and online. I am talking through a mask because, funnily enough, we're talking about RSV and I've got some sort of respiratory virus at the moment. So, welcome to winter. Anyway, I'm Sam McFedries. I'm the Translational Research Lead for the Randwick Health and Innovation Precinct. And this regular research seminar series falls under the guise of the Translational Research Working Group. And so it's something that we try and hold monthly, but this year has been a bit of a slow start. So this is actually our first one for the year. But anyway, I just want to welcome everybody. I'd like to also acknowledge the Bidjigal people of the Aurora Nation, the traditional custodians of the land where we are located in Randwick today. However, also acknowledge the lands that colleagues are joining us online from. We pay our respects to their culture, their elders past, present and emerging, and we extend that respect to any Aboriginal or Torres Strait Islander peoples here today. So I'm really delighted to introduce our two speakers today. First up, we've got Dr. Nusrat Homaira, who is a medically trained respiratory epidemiologist who's currently working as a senior lecturer within the discipline of child health, Paediatrics and child health, at UNSW Sydney, and also a respiratory scientist at Sydney Children's Hospital here in Randwick. She's got over 15 years working experience in child health research in both low and high income countries. And today she'll be speaking to us on respiratory syncytial virus or RSV, which again is very timely given the time of year, and also that last week was RSV Awareness Week. So I'll throw over to Nusrat.
Thanks, Sam. I want to begin by acknowledging the traditional custodian of the land on which we gather today, and also the custodians of the lands on which I work and I live. I want to pay my respect to Aboriginal and Torres Strait Islander elders past, present, and emerging, and any Aboriginal and or Torres Strait Islander people among us today. So thanks, Sam. Thanks for organizing this. I know some of you are online. So we're going to talk about RSV today, which is a very sort of topical subject right now, primarily because it's winter, and this is a respiratory virus and a winter virus, and everybody's getting sick, children, adults, everybody's getting sick. And secondly, because I'm sure many of you are already aware that there are multiple RSV preventative immunoprophylaxis in the pipeline, which one of them has already become available. Another one is going to become available in another 5 to 6 months in Australia, already being used in other settings. I'm going to talk about that in a while. So it's a very exciting time for RSV. And without any further delay, so RSV, or respiratory syncytial virus, is the major viral etiology associated with acute lower respiratory infection hospitalization in children, more specifically in the first 6 months of age. And those of us who are associated with a hospital or work in a hospital are very much aware of how our wards look like during the winter months. All our wards get overstretched, the pediatric wards, and it's mostly all respiratory hospitalization or bronchiolitis hospitalization. And when we see those hospitalization, you can quote me on this, 60 to 80% of those are due to RSV. So annually, there's around more than 30 million of RSV episodes, acute lower respiratory episodes across the world, and which results in almost 4 million hospitalization. And this can be a gross underestimation because, RSV testing in different countries, different settings is very different. But clearly there is a huge significant burden globally from RSV. It's also associated with significant number of deaths, unfortunately, mostly in low middle income countries. So I'm not going to bore you with the virology of it. So this is an single-stranded RNA virus, and it has two major proteins, the F protein and the G protein, which helps the virus to attach to the host cell and then sort of replicate. And there are two main subtypes of the virus. Unlike influenza virus, it's a little bit more stable virus, so it does not continuously mutate and form new variants. So there are two main subtypes, the RSV A and B. And in one season, one of the subtypes can be predominantly circulating, but both the subtypes can also circulate in a particular season. There's no sort of clear understanding between the severity, like do you get more severely sick if you are infected with A versus B? Some say there is a little bit more severity with A, some data suggests B, so it's not very clearly understood. So the disease, again, thankfully, in majority of the children, RSV will cause upper respiratory tract infections, so a bit of sniffles, cold, cough, but it can move downwards. It can infect the lower respiratory tract infection, where it causes necrosis and sloughing of the respiratory epithelium, resulting in huge mucus secretion and blocking of the airway, which then results in difficulty of breathing. So oftentimes when we see the kids come into our emergency department or are hospitalized, they're struggling to breathe, or they have wheezy chest. So these are severe symptoms of RSV. Thankfully, in majority of the cases, it's a viral infection, so it's a self-limiting disease. There's no effective treatment available yet for RSV in children. It's mostly supportive treatment, and children normally get well within 2 to 3 weeks. Like I said, that 80% of children within their first 2 years of their life will get infected by RSV. So almost all of us who have children, and all of us, we have been infected with RSV at some point. And the bad thing and the good thing about this virus, it keeps on reinfecting. So we get reinfected throughout our lives, but the subsequent infections are generally milder. Mostly in adults, we don't see strong symptoms. But of all the children who are infected, 30% of them will develop a severe disease, which will require them to come to hospital. And around 10% of those who develop a severe disease will be hospitalized. And around 16 to 20% will end up in intensive care unit. And again, death is relatively rare, but that is mostly concentrated in the low middle income countries. So looking into Australian context, the context that I've given to you right now was global context. So what do we know about RSV, or what we don't know about RSV in Australian children? Like other places in the world, RSV is also the leading cause of hospitalization in our children less than 2 years of age. Unfortunately, prior to COVID-19, there was no routine testing of RSV, primarily because there is no effective treatment available. There was no effective preventative strategies available as well. So oftentimes clinicians' attitude to RSV would be, so why do we even care? Like, how does it matter whether it's RSV versus rhino or any other virus? So that's why the testing was very limited. Fortunately, in 2021, beyond 2021, RSV became a notifiable disease in Australia. So what that means is, if somebody is tested positive for RSV, it has to be reported to the National Notifiable Disease Surveillance System. Because of that, and because of COVID, testing for RSV across the country has substantially improved. Within our hospital and within Westmead, all children who are hospitalized now with acute lower respiratory infection are tested for RSV. They're tested for a whole range of viruses, including RSV. So testing has improved. So this is the seasonality, or again, what we don't know about the seasonality. So RSV is a winter virus. In temperate regions, there's a clear seasonal peak. Unfortunately, in Australia, we have both tropical and temperate region. That's why you'll see the seasonality varies. The season with New South Wales and Victoria seeing clear winter peaks, whereas if you go to Northern Territory and top part of the country, the seasonality can differ. Even within Western Australia, the seasonality can differ. So why even show this? Firstly, you need to know the seasonality of a virus which has a seasonal distribution, because if you know the seasonality, then we can prepare our hospitals like, okay, this is the month where we are going to get a lot of cases of RSV. So we need to have our beds free, or we need to have a strategy in place. How do we cohort these children, or how do we plan our healthcare system, right? So that's why we need to know seasonality. The second important reason that we need to know seasonality for, you all must be aware of the flu vaccine, and how we say, this is the flu vaccine time, go get your flu vaccine, because again, influenza is a seasonal virus. And so that's why the vaccine has to be given within a certain time period. So when we have a seasonal virus that circulates or predominantly circulates during particular months, it's very important to understand the seasonality. Then we can target the interventions during those months. That's why it's very important. However, what has happened is, like all the other things that COVID has disrupted the seasonality of RSV as well. So this is our data from the two hospitals, our networks hospital, Westmead and Children's Hospital. We've published this work. So you can see in this figure, the red lines are, the COVID year. And the other blue lines are the years prior to COVID. Before COVID, we had a clear sort of winter months peak in RSV presentations. But when COVID came in, what happened was, as you know, COVID, to limit the transmission of the pandemic, we had a lot of public health measures in place, which meant we could not see each other, which meant we could not gather anywhere. Children were not allowed to go to school. So RSV is a respiratory virus. All respiratory viruses have more or less a similar transmission dynamic. So you have to be in close contact with a person, another infected person, to get the virus. When you don't let that happen, of course, transmission also gets affected. So that's what happened during COVID was we had all these public health interventions. People were not mixing together. People were wearing masks, washing hands. It just limited the transmission. And once those public health measures were lifted up, we were mixing again. We were gathering in one place again. So transmission again picked up. And so we saw a later peak in RSV circulation. So we saw a lot of cases coming into our hospital during the summer months, during the end of the year, October, November, December, which is very unlikely for RSV. Now we are slowly going back to a near normal phase of RSV, but we're still not there. Even this year, we had an earlier surge of RSV cases, which is, again, we're not there. But I think from what I understand of the epidemiology of the virus, maybe in another 1 to 2 years, we are going to go back to the same sort of seasonal pattern of the virus. So looking into the RSV hospitalization, like I said, that we don't have much data on testing because RSV was not routinely tested. Even now, we don't know what happens in the primary care setting. How many of the children who go to primary care setting, like GPs, get tested? And as you all know, the bulk of the children will actually go to GPs before they come to the hospital. So we don't have any data. In Australia, we do not know what's happening there. But we do have an understanding of what happens in the hospital. So based on the hospital, what we see is that primarily children who have RSV, when they're hospitalized with bronchiolitis. So that's the primary diagnosis in children because these are less than 2 years of age. And then majority of this RSV hospitalization in children less than 2 years of age. And also in Australian context, around 7% of children who are hospitalized with RSV end up in intensive care unit. That's a big number. And if you look into this graph, this shows the age distribution, and you can clearly see that the 0 to 2 months, which is the blue line, that is where the highest rate of hospitalization is. And as children grow up, the hospitalization rate also reduces. We basically don't see a lot of hospitalization beyond the age of 2 years. We still see, but very few. It's really in the first 2 years that we see majority of the hospitalization. So risk factors for RSV hospitalization, of course, there are some socio-demographic risk factors. There are some certain groups of children who are at higher risk, and there are some genetic susceptibility as well. In terms of the environmental risk factors, age, like I said, remains a big predictor for severe RSV disease. So younger children, more likely to be hospitalized. Male children, more likely to be hospitalized. And the hypothesis around that is male children have shorter airway, hence, they have more severe disease and all that. So also children who are born during the RSV season have higher chance because there's a lot of circulation going on. Children living in crowded environment or daycare settings, low socioeconomic environment with higher levels of environmental pollution and smoke exposure are at higher risk. And there's certain groups. In Australia, our First Nations children or Aboriginal Indigenous children are at 4 to 5 times greater risk of developing severe RSV disease compared to non-Aboriginal children. While a lot of this risk is due to the systemic socio-demographic disparities that they suffer from or are born into, there are other factors as well, which is not clearly understood. But our Indigenous community continue to remain in high risk of severe RSV disease. Children who are born preterm, gestational age less than 37 weeks, children born with chronic lung disease of prematurity, bronchopulmonary dysplasia, or children born with congenital heart disease or immune deficiency Down syndrome, they are also particularly at higher risk. So this is looking into our own data. So this is data from our children who come to our hospital, the 2 hospitals in the network, Randwick and Westmead. So we looked into, what are the symptoms, what are the clinical presentations that can decide whether this child is going to end up into ICU if the child has RSV or not. So what we did was we compared those children who came in with RSV to our hospitals and were not taken into ICU. And then the other group was children who came into our hospitals with RSV, but ended up in ICU. So we had two groups. And so these are some of the factors, clinical presentations that were very relevant. But what I really want to bring your attention to is apnea. Apnea remains a major symptom for ICU admission. Oftentimes, parents will come and tell you that my child did not breathe for a fraction of seconds or was holding their breath. This remains a significant predictor for poor outcome in children with RSV. So this is Remy. I wanted to show you Remy's. I don't know what happened. This looks very clumsy, but anyways, so this is Remy. Remy first developed severe RSV disease when he was only 3 weeks of age. Their family lives in a regional New South Wales. Remy was then transported to our hospital. Remy was in the intensive care unit, was put on mechanical ventilation. Remy had a severe prognosis of the disease. Remy still continues to suffer and keeps coming back to our hospital. So RSV can be a real problem. And when Remy presented to their regional hospital, Remy's mom's main complaint was Remy was holding his breath for a fraction of a second. So looking into RSV versus other viruses, of course, this is winter months. All the viruses are co-circulating, and there's influenza, there's rhino, there's adeno, there's human metapneumovirus, parainfluenza virus. So is RSV any bigger threat than those other viruses in our children? Well, it is. So this is the data from our two hospitals again, so Randwick and Westmead. What we did was we compared children who came in with RSV and were hospitalized, and children who came in with acute lower respiratory infection were hospitalized but did not have RSV. They had some other virus, okay? And both these groups were children who were less than 2 years of age, hospitalized across the two sites and hospitalized with acute lower respiratory infection. So when we compared those two groups, we saw that RSV was actually associated with more complex disease. So these kids had more cough, more fever, more tachypnea, hypoxia, and lethargy. They were also more likely to be hospitalized longer. So they were hospitalized for 2 or more days compared to more. And the most important two findings is these kids who had RSV compared to other viruses underwent a lot of chest x-ray. So 70% of them underwent chest x-ray compared to only less than 50% in the other group. And, in this age group, chest x-ray is really not recommended, which is actually even harmful for that age group. And these children also received a lot of antibiotics. 62% of those children who had RSV compared to only 35% who did not have RSV received antibiotics. And I just wanted to highlight that, inappropriate or irrational use of antibiotics for lower respiratory infection in children is one of the key factors for emergence of antimicrobial resistance globally. So we need to think about those things as well, but it's not to blame anyone, but I think because of the severity of disease in these children, clinicians are often inclined to prescribe antibiotics. Looking into deaths from New South Wales, fortunately, we haven't had too many deaths. Deaths are still small numbers for us, and mostly in older children. We don't see a lot of deaths in the younger children. And there's a lot of deaths. The deaths also happen due to hospital-acquired infection of RSV. So hospital-acquired infection of RSV is also a problem. So risk factors, if we look into the risk factors of RSV, it's just like those risk factors that I showed you, but mostly if a child has a pre-existing chronic condition, then that child, when they get an RSV infection, are likely to die. So that's pre-existing condition or chronic condition is a huge predictor for poor outcome, which is death for RSV. Unfortunately, where the majority of the deaths are concentrated, that's low middle income countries, existing chronic condition does not seem to be a big player. The biggest player there is the poor socioeconomic environment that they live in. The overcrowding situation, the high level of smokes, environmental pollution, and no access to potable water, no access to good sewage system and all that. All those things actually put them at higher risk. So economic burden, a disease that, that is a problem for so many children, that infects children when they're really young, is also associated with a significant burden on our healthcare system. Each episode of RSV hospitalization in Australia results in more than $6,000 to the healthcare system. This is direct cost, which is much greater than what we see for influenza or rotavirus. Okay, and also annually, the direct cost to our healthcare system from childhood RSV hospitalization is between 24 to 50 million. So that's a lot of money. However, I don't particularly like this slide because we talk about the dollars a lot in this slide, but these are very young children. Their families come to the hospital when they're hospitalized, and we have no understanding of the indirect cost. And just imagine if my child, 3 weeks old, was in the ICU with RSV, the burden, the mental, the psychological burden that it would create on me could never be measured in dollar terms. So we should not forget that while there is a huge direct cost, there is a significant indirect burden associated with RSV to families and parents and carers of the children that we care for. This is a slide that I particularly like because it's a topic of great interest to me. So I often say that this is a double-barrel virus. So you have a young child gets RSV, gets really severely unwell, has to be hospitalized, then gets well and goes back home. But then this child goes on to develop asthma. So 10% of children who develop RSV when they're really babies, like less than 2 years of age, will go on to develop asthma. And so there is now mounting evidence suggesting the causal relationship between early severe RSV and then asthma at a later stage. So you have that huge pressure of acute disease from RSV, but then also you have the burden of chronic disease. And as you all may know, asthma remains the leading chronic respiratory cause for our Australian children. 1 in every 10 Australian children have a current diagnosis of asthma. So again, we have a huge burden of asthma as well. So to sum it up, like I said, that even though having an underlying condition is a risk factor, majority of the children who come to our hospitals will be otherwise healthy. And young children are at significantly higher risk. And what's about the prevention? Up until 2022, we had only one monoclonal antibody, which is called palivizumab or Synagis. Palivizumab was only recommended for use in children who were born preterm or had underlying chronic lung and heart disease, partly because it's a very expensive monoclonal antibody. So it was not widely recommended for all children. And it was also not recommended for Indigenous children in New South Wales. In Western Australia, there was recommendation for Indigenous children. So that's why use of palivizumab remains limited, even in the most developed countries, because of the cost. However, the landscape is changing. We now have multiple preventative immunoprophylaxis. There is a monoclonal antibody. So both of these are immunizations. They're not vaccines. So immunization is, when an antibody is given to your body. Our vaccination is when your body produces an antibody. So what we have is we have a monoclonal antibody, which is given to infants after they're born. And then that mounts the antibody and helps the child fight against RSV. And then we have a maternal vaccine. That is a vaccine for the mother, but not for the child. So that vaccine is given to the women when they're pregnant, just like flu vaccine or pertussis vaccine. And then that enhances the level of antibody that is transferred to the baby and helps the baby to be protected in the first 6 months of life. So these are the 2 forerunners we have right now. So I'm not going to go into this detail, but the maternal RSV vaccine, there was a GSK vaccine trial going on, which was suspended because there was side effects associated with the vaccine. But we now have a vaccine by Pfizer, which was FDA approved in August 2023. And CDC put it in their recommendation, in the American immunization recommendation in September 2023. And the monoclonal antibody, which is nirsevimab or Beyfortus, produced by Sanofi, is also has received FDA approval. And it has been administered in the last winter in UK, Europe, and USA. And the vaccine has also been administered in multiple places. So these are some of the recommendations, global recommendations. In most of the places where they have both, they're recommending both to be used. The cost effectiveness suggests that the maternal vaccine might be more cost effective than the monoclonal antibody, partly because monoclonal antibodies are always expensive. In majority of the countries, the way they are going to go forward is everybody gets the maternal vaccine and high-risk children also get the monoclonal antibody. That's the understanding right now. So this is the real world data. So both of these have been used in the last season in US and Europe. So USA, it suggests that, between coverage of 4 to 12% for the monoclonal antibody because there was a serious shortage. But when there was a coverage, the efficacy is 90%. So it's working really well. In Europe, the coverage has been very good and the efficacy has been also very good, more than 80%. So it seems like the monoclonal antibody is doing what it's supposed to do. What's happening in Australia? Both of these have now been approved by TGA in Australia. The monoclonal antibody has been approved, and so is the maternal vaccine. The monoclonal antibody has been approved, but it's only given to all infants in Western Australia and in Queensland. In now New South Wales, it's only being recommended for high-risk children. Again, there's a problem. There's a huge issues with the supply. We don't have enough nirsevimab. So while it's being recommended, it's the access issue is still there. The maternal vaccine has been TGA approved, but it has not been listed in PBSE yet. And it is because of cost issues. So they're looking into the cost. Okay, so we have done some analysis and it suggests that if the vaccine's cost is kept at $120, then it will be cost effective for Australia. So this is the Australian context. We have the monoclonal antibody, which is being administered this season to all children in Western Australia and Queensland and to some children in New South Wales. The vaccine is not being administered anywhere in Australia. Potentially next season, we are going to see the vaccine as well. So before we go, I hope I didn't take up Iain's time. So before we go, this is the data for this year. Just imagine how quickly RSV cases are rising. This is not really when we see a lot of RSV cases. We have had a very early peak this year. And this is the notifiable data, right? I told you that this has now become a notifiable disease. So RSV is picking up and the majority of the numbers have been reported from New South Wales, which is not unlikely given we are the most densely populated state in the country. So before we go, I just want to remind you that this virus is real and this problem is real. And it affects the most vulnerable ones, our children. And unfortunately, we have a way, or we have multiple ways to prevent it right now. So I think we should all advocate for an effective prevention so that the preventative strategies are incorporated within a national program. Rather than having a state-based funded program, we need a nationally funded program to have prevention against this disease. And with that, I would like to, I hope I have convinced you RSV is a real problem. Thank you. And I'm happy to take questions if there is, any time left.
Thanks, Nusrat. There's definitely some time for some questions. I'll open it up to the room here, but also anyone online, if you've got any questions, you can come off mute or you can put them in the chat and I'll keep an eye on it. But
it's a great talk and body of work. Thank you. I think anyone with kids is considers RSV very real, very important. Caught my eye that boys are so much more susceptible to severe illness than girls. And
just even picking up RSV, So yeah, the thing is with male children, any respiratory infection, they have a higher risk. And the hypothesis is male children have a shorter airway compared to, the girl child. So they are more at risk of picking up respiratory viruses and getting more severely ill. And we see that more with RSV as well.
And is that factor similar between the respiratory viruses? So that 1.5 to 2?
We see that with other things as well, even with asthma, we see more asthma in males than females.
Can I have another one? Or?
Yeah.
The data you had on the COVID lockdown, I'm going to keep talking about this, on the COVID lockdown and the suppression during winter and the elevated rates in the summer period, cumulatively, was that the same across the year? So by the end of that sort of period of time, the same amount of infections?
Yes. So Iain, what happened is we saw a later peak and we also saw older children. So, RSV is more in the first 6 months, but once COVID public health interventions were lifted up, we saw those kids coming in with RSV were a little older. So they were between 12 months to 18 months of age. However, the peaks were no greater compared to previous years. We didn't see more infection, but we saw a later surge of infection, if that makes sense.
It does.
Yeah.
No, sorry, I just got a question online. So Jack has asked, why do children with RSV get chest x-rays and antibiotics so often despite there being a PCR test for RSV? Oh, sorry. I don't want to say too much on the mic. So, sorry, why do children with RSV get chest x-rays and antibiotics so often despite there being a PCR test for RSV? And are there evidence-based practice guidelines for this process?
That's a very, very interesting question, and that's a black box in itself. Evidence-based guidelines, and do we actually adhere to that? So there are guidelines for bronchiolitis management. There is, Royal Children's Hospital's guideline. There's our hospital's guidelines. There's all these guidelines, but we also know having a guidelines does not automatically ensure that the guidelines is followed. Oftentimes these guidelines are complicated. Oftentimes these guidelines are not readily available at the point of care. And also, clinicians take a lot of decisions based on their experience. So I think what happens with RSV is, I've shown you that children with RSV present with more severe disease. So they have more fever, they have more cough, they have more wheezing and all that. So, and these are young babies. So I think clinicians often, as a precautionary sort of strategy, use antibiotics. But yes, yeah.
How common is a co-occurring bacterial infection
Yes.
alongside RSV?
I was hoping somebody would ask that question. So when we looked into that data, I didn't show all those data. What we saw was that, so we had data from 660 children who came into this hospital, right? And so of that, almost 46% had a co-infection. So they were infected with 2 or more viruses. And the remaining were just single virus, say RSV or rhino or flu and parainfluenza. But what we did was, and May, who's in our team, she looked into all that data. So what we saw was that when we compared between co-infections, so say a child has RSV with another virus, right? And the child who has just RSV based on PCR testing, the disease severity did not differ. Okay, so viral co-infection did not really impact the disease severity. However, bacterial co-infection can be tricky. But we did not look into bacterial co-infection, partly because, just identifying bacterial nuclei from PCR is not a very step, because often a lot of those bacteria are present as normal commensals. So PCR testing and presence of bacteria does not really mean anything. But there are some data that suggest if a child has bacterial co-infection with an RSV, then they are more likely to have a more severe disease. But these children did not have any bacterial pathogen also identified in the PCR. These were just viral pathogens.
Thank you.
Any other questions, Sam?
All right, so our second speaker today is Dr. Iain Perkes, and Iain is a clinical academic, a child and adolescent psychiatrist for Sydney Children's Hospital's Network Mental Health Services and UNSW Sydney. Iain has significant national and international reputation in the area of child and adolescent mental health, including pediatric obsessive compulsive disorder, on which he will be speaking about today. I would also like to just give a little plug for the Developing Brain Clinical Research Colloquium that Iain and colleagues are organising. It's now in its 3rd year. Registrations are open and the colloquium will be held on the 26th of August here at Sydney Children's Hospital. So I implore you to have a look at that, and if interested, register to come along and join colleagues there. I'll hand over to Iain now.
Okay. Yeah, so talking today on OCD in a mix of clinical context and research data. Okay.
On Zoom.
Sure.
Sorry. Here we go. Sorry about that.
That's okay. Yeah, so talking on OCD, and I think the first thing to sort of point to, this is an uncomfortable slide to look at, but it's important to convey how severe OCD can be for some people. I think that the phrase, you know, so OCD or a bit OCD, there is some truth in that, insofar as many people without OCD will occasionally experience an obsession or a compulsion, but for people without the condition, those sort of troubling or sort of unwanted thoughts will just sort of come and go. They don't really have any difficulty letting go of that thought. For people with OCD, those thoughts really take root or recur and recur and recur and have a really very profound, in some cases, impact on daily life. So some people are completely housebound by the condition, and sadly that, you know, that level of illness can occur in children. So this is a quote from patient that came through the service. They were very, family were very insistent or supportive, encouraging of us using these words, really wanted to convey the lived experience there. So in terms of what OCD is, I think people probably have a general concept of it, even sort of general community, but it's basically a set of intrusive thoughts. Not only thoughts though, can be images, so mental pictures, can also be urges. So like a feeling as though one has to do something, not necessarily a crystallized, clear thought, declarative thought that you could easily articulate necessarily. And then there is a behaviour or an act, and it can be a mental act or it can be a physical act, most often a physical act, but it's good to be aware that those acts can be mental also. So for a mental act example would be counting internally, so 1, 2, 3, 4, or up to a certain number in a repetitive manner. This could be very, at its most innocuous form, just distracting. So you can imagine if you're sort of mentally counting when you're hopefully supposed to listen to this lecture, for instance, or if you're a young person in school, in class, trying to attend to what's being taught, that would be very, very difficult. It's a very common condition. So the total prevalence across Australian society is for adults is 750,000 Australian adults living with OCD. That predominantly has its onset in childhood or adolescence. So there's two peaks of onset. There's around 10 and 11 years of age for the first peak of onset, and the second peak being 18 to 20, sort of late adolescence, early adulthood. Some younger children, 3, 4 would be very, very young, but you do get some repetitive behaviours in around that age that can herald the later onset of OCD. Commonly, people live with OCD for years before they receive any form of treatment. That's very common. So in adults, it's around 9 years before they receive active treatment for the condition. In children and adolescents, it's depending on the precinct, but maybe around 2 years, 18 months, which doesn't sound terribly long to some, perhaps, but thinking about living with these conditions in a developmentally sensitive part of your life where you're supposed to be achieving or supposed to have the opportunity to achieve these developmental milestones. So there's a real cost there. So as I said, school can be greatly impacted. So from the Australian national data, just due to OCD alone, 3 or 4 weeks of school missed, and that's not accounting for co-occurring related conditions or RSV or other things that we all know will happen to the general community. So you can imagine the impact there. The economic impact is massive. It's $3.4 million in direct healthcare costs. Despite this, it's a relatively underfunded condition, both in terms of clinical services, but these are research data that we analysed and published in terms of NH and MRC funding. This is just for mental health or brain-based conditions, and we can see that dementia, quite rightly, dementia is a really profoundly important condition. So this is not the politics of envy. These conditions should be funded for research. With dementia, getting a fair amount there, and psychosis, autism, eating disorders, and in behind them all, being OCD. So despite this, we've got some good news. So 2/3 of people will respond in full remission from OCD if you deliver the first line therapy, which is a behavioural type therapy. So it's a type of cognitive behavioural therapy, exposure and response prevention. Medications work quite well. We've got multiple medications shown by RCTs, meta-analysis of RCTs, in fact, so highly effective. So we have some good treatments available. There are some people that don't respond, but despite the availability of these treatments, they're not commonly offered. They're very hard to access. So getting high quality behavioural therapy in community, in real world, is extraordinarily difficult. So saying that 20 to 30%, that's of psychologists offer it. And when you drill down deeper, the number is probably 5 or 6% of providers that would offer higher fidelity, like the approaching the fidelity or the type of therapy that you get in a clinical trial is really different from medicines. So with medicines, it's not that hard to deliver it in a way that approximates a clinical trial. We've got a much easier gig as prescribers relative to the behavioural therapists. It's very hard in practice. So it's not a criticism of the providers. Just trying to emphasise that if this was easy and straightforward, people would be doing it. You know, the psychologists and other providers want to do this. It's not a lack of motivation on anyone's part. Unfortunately, the duration of untreated illness predicts poorer outcome. So it sort of makes sense to most people. I would think the longer you let an illness run, the harder it becomes to treat it. You get complications, you get sort of learnt behaviours associated with it, you get some helplessness creeping in among the family. So we also looked at hospital admission data in the acute inpatient units. It's 9% of admissions, but 15% of bed days total, because children with OCD stay in longer. Of the voluntary admissions, it was the highest proportion. So the children and young people that are coming in in an agreeable state rather than under the Mental Health Act. So indicating that people are quite relatively engaged with treatment. It's about 93% with voluntary. So they're agreeable to sort of receive treatment. Despite this, it's the second longest length of stay and accordingly cost of admission. So the cost per admission, $64,000 per admission for a child or young person with OCD in the network. So cumulatively across this cohort from the year range, I think this is 2016 to 2022, it's $4 million of direct healthcare costs within the network for these young people. That expands out to 11 million if you're including the secondary diagnosis. So someone that might have come in with, for instance, depression, but also has a diagnosis of OCD. So if you include those, despite that long length of stay, second highest remission rate. So indicating perhaps that hospital is not the most appropriate place to be treating OCD, that it's a complex setting to deliver the types of therapies required, and perhaps the community-based care, there's opportunities there to do more. So against that broad background and the local data, we've established across the spectrum clinical service for paediatric OCD, from the very pointy end, the extreme cases, across the subclinical. Talking about the pointy end first, so for the very extreme type cases, the sorts of cases that were coming into the hospital before we started this program, we have a wraparound program of care where we work with the local community team. So South East Sydney Local Health District, I should emphasise this work's been supported by funding, including from Mindgardens Neuroscience Network, also UNSW, Sydney Children's Hospital Foundation. So we're really grateful for that support. So the type of care, the tip of the spear is that behavioural therapy that I've mentioned, but it's a team-based care, multidisciplinary assessment, close liaison with the sort of core treating team, if you like. Happy to talk more to it. And we're seeing excellent effects. So large effect sizes in terms of symptom reduction and family accommodation. So family accommodation, meaning that the family is quite understandably adapting to the compulsions. And so an example might be they're rushing out to buy lots of soap so the young person can wash their hands with soap. So that's it's a very understandable phenomenon very common. Most people do it, but actually it's associated with poorer outcomes. It sort of feeds the OCD cycle, if you like. So, but these are, I guess, the thing to emphasise here, and it's probably the next slide, is that these are real world cases. So this is a composite of some of the cases, so it's de-identified. So 14-year-old girl, extreme symptoms, unable to attend school, so housebound, can't get out, right? Has had 3 previous hospital admissions, advised that symptoms were too severe for therapy. This is something that we see fairly commonly, and this is not intended as a criticism about providers. They're acting on, you know, it's a little bit like people prescribing antibiotics, right? In the previous talk, people are acting with the best of intent and with their clinical training and the information they have available to them. Despite that, this young person engaged extremely well, and that's been, as a rule, all these young people have done phenomenally well. It's very, I can talk to why it is, but it can be a very scary thing for young people to deal with. Engaged well, had a terrific response, so went from basically being housebound to attending TAFE, getting on public transport, getting out to restaurants, really quite heartwarming and exciting. Family quality of life's also improved. So that's the point here that I talked about. Other work that we're doing, and this is published work also, is a national network, clinician network, so that for the milder type cases, people can navigate toward a private provider that has a special interest activity experience with OCD. It's a peer-nominated process, and so we check that they're registered on APRA with no conditions, but beyond that, there's no accreditation process. But this seems to be helpful to people, so we're proud of that work. Also doing community engagement advocacy. So there's a piece we wrote for The Conversation to sort of raise awareness. It was a very well read piece. So as I said, it's real world research, real world cases, and there's real world implications. So this is a model of care that's rolling out now. We're coming towards the end of that initial implementation feasibility trial, or effectiveness feasibility trial, I should say. It's scalable. It saves cost in terms of hospital admissions, reduces risk associated with coming into hospital. Any type of hospital admission carries some risk. Psychiatric admissions are no different. I might have got carried away here about sustainability, but I guess a principle of what we're doing is capacity building. So we're training clinicians in the mainstream services to provide ERP, providing education for parents and so on and so forth. So those are the slides, and yeah, finished with 5 minutes to go. So yeah, happy to take any questions. Yep.
Yeah. Well, look, we can just talk to each other.
Iain, I believe you're providing education to clinicians and training them so that they can educate parents as well, right?
Yes, that's
Or
right.
provide the proper information.
We do it at a few levels. So we run in-services, which are relatively informal about and how clinicians can then provide education. We haven't particularly measured that, but the other thing that we've done is training clinicians in providing group-based therapy. I didn't talk to that. So there's evidence that you can have 8 kids in a group receiving this behavioural therapy, and that shows equivalency with one-to-one therapy for certain types of cases, not the sorts of cases that we're putting through intensive. So as part of that, we've trained 18 clinicians across 6 clinical teams in SCHN. We showed large effect sizes in increased competency, knowledge, confidence in delivery of ERP. So theoretically, that group of clinicians could treat 200 kids per year. There's real implementation science is very challenging. I think you can train people, but there are multiple systems factors that can sort of conspire to make delivery of those groups challenging, but they are still running. So we're past that phase of the trial of the work, but those groups are still being run by SCHN. So I would say it's a success with a caveat that it's complicated and you got to sort of think through what are the enablers, the barriers. Yeah.
Are you doing anything with primary care providers?
That's it. Not yet is the answer, but like I think it's be good to talk to you afterwards, perhaps, about how to approach that. It's a very complicated space in terms of
I
like
know. That's-
individual general practices, which are independent businesses effectively.
Yeah,
And
exactly.
I think there's also, from the hospital's perspective, to some degree, that like our kind of remit is the pointy end, if you like. But we certainly have an eye on that space and trying to sort of build towards something there. We've done some work, like we wrote an article for GPs in terms of how to commence treatment for paediatric OCD in general practice. And we sort of put that out there, and that's been well read. But we haven't sort of measured the impact on competency or effect on care. But if you've got any suggestions.
No, exactly.
that
That's
you-
our struggle too,
Right.
with some of our asthma work, because, you know, and I feel like increasingly clinician researchers, we tend to be focused in the area or environment where we are comfortable. Like we know the hospital, we know the people here. So most of our researchers are focused within the hospital, whereas we clearly know the biggest burden is in the primary care setting. And some of the issues that you have pointed out, we are also experiencing this. So that's why I wanted to know your thought. We are struggling with that too. We are going to roll out a big national project in primary care setting that is going to provide us some insight and experience of, we are trying to implement a model of care that we have, you know, done in hospital setting. Now we are taking it to primary care. So
I'll be fascinated to hear. I mean, one approach there that I've seen from eating disorders is to empower patients and carers, and sort of provide that education about how you assess for symptoms and have some self-report forms, having treatment protocols, and they can attend GP with that information. I'm not sure how that lands. You know, it sounds very appealing. I'm not sure in practice, in rooms, how that works out.
exactly,
Yeah.
we don't even know. So we'll see how it goes. That's what I wanted to have.
Thank you. It's a good question. No, please.
I'm loud, I don't need it.
They want it for online.
My question is, you mentioned there were two peaks in kind of OCD, one around about 10 and 11 years old, and the other one in late teens. Is that right?
Yes.
I wondered, for those probably mostly untreated, what's the likelihood of them going on to develop major mental health issues, in particular a psychosis?
Oh, it's a loaded question, Owen.
Yeah.
So I'm going to turn it around and say OCD is a major mental health issue.
Yeah.
So if we look at like the level of impairment on a case by case basis, OCD is comparable to schizophrenia. Now, you need to partition it somewhat to arrive at that conclusion, but it is in and of itself a major mental health issue. It is a severe mental illness.
Probably the bad language to have used. I apologize for that, because yes, I agree it is.
Yes.
The reason I asked that question is that I've come over recently from adult mental health, and often a lot of the people who are involved with EPP, early psychosis program, their journey towards their initial kind of first episode has been presented often with a lot of OCD, ADHD kind of diagnoses.
Yeah.
And I'm just wondering, is it a misdiagnosis of OCD and there've been prodromal things going on there, or?
No, I don't think it's a misdiagnosis in most cases. I'm sure it is in some. In terms of the diagnostic stability and predictors of future development of different conditions. So there's an association between early diagnosis of separation anxiety and later diagnosis of OCD. There is a slightly but not profound elevated rate of diagnosis of schizophrenia in later life if you have an earlier diagnosis of OCD. I suppose what I always, try to do is play it as it plays. So as in, I mean, that's a bit blithe, I guess, when you're talking about people's healthcare, but the patient, the person with lived experiences in front of you, if they currently meet criteria for OCD, then that's what you're treating. And if that later transitions into something else, then that's what you're treating. And if that happens, that's not a misdiagnosis per se. That's just things have changed.
Transition.
Yeah, I think, and if you look at the prevalence data and the duration of untreated illness, OCD dwarfs psychosis. It's 2 to 3 times as common, and it's got a duration of untreated illness, which is, depending if you're an adult or children, about 9 times longer. So in terms of, are we missing a diagnosis of psychosis? No. we're missing a diagnosis of OCD. It's the other way around. I'm sure we missed some psychosis, in case anyone's listening and I get some emails.
Good, thanks
That's a
very
great
much.
question, Owen. Thank you. Yeah,
Thanks.
well done.
No, there's nothing online, because that's not quiet.
Thanks, Sam. Thanks for organising.